So many times, sarcomas are very common in pediatric age group, but sometimes you are faced with very, very small children. So this is a 3.5-year-old boy, had an Ewing sarcoma of proximal tibia. If you can see, there is a lesion, long segment involvement of metadiaphysis. On an MRI, the disease is almost touching the physis, but not crossing the physis. Goes all the way almost up to the distal, middle third, distal third junction. These are some more images which is showing that the disease is not crossing the physis, proximal tibial physis. An MRI shows there is a large posterolateral mass, but usually these patients respond very well to induction chemotherapy. He was fortunately non-metastatic. The chemotherapy was given, and at post-chemotherapy you can see an excellent response. The tumor boundaries are now very well marginated. The soft tissue mass has vanished. As you can see here, the tumor is now restricted inside the bone, very little periosteal elevation. The physis is clear. The disease is not crossing the physis, but it is touching the physis. These are some more images. As you can see here, the physeal epiphysis is absolutely clean, and the disease is all below the physis. But as for oncological safety, my proximal cut would probably go through the physis, and that will create a lot of limb-length discrepancy. Now, child is only 3 years old. If you lose the proximal physis, the limb-length discrepancy is going to be immense by the time he grows up. So here we have advocated a very unique procedure which is known as Canadell's procedure. The principle of Canadell procedure is basically physeal distraction, and it, of course, almost in all the patients we can preserve the joint, and in almost 52% of the cases we can even preserve the growth. If you look at the histopathology of physis, it is made up of multiple zones. By doing a physeal distraction, actually you are distracting the physis between the maturation zone and the degenerative zone. And in almost all these patients where the physeal distraction has happened here, you can preserve the growth. So the step 1 was to do a physeal distraction in attempt to preserve the growth, and the step 2 would be to do an intercalary resection and reconstruction. So we put up this distractor. The pins are in the uninvolved area, and indeed it got distracted. As you can see, usually the child is sent home and ask them to distract 1 millimeter every day. The physeal plate has now broken. Patient typically has some pain and some snapping sound. The next day we take up the patient, and for this young boy we had to do a 3D customization of the plate, because for this reconstruction we don't have any available implants. We also wanted to save the distal physis. The distractor was removed. Typical intercalary resection was done. As you can see, you could actually cut the proximal thing with just the help of a knife because it is distracted. This also improves my proximal margin. Once the distraction has taken place, once the resection is done, it was sent for extracorporeal radiation therapy. This came back from the radiation therapy. It was then mounted back on the distal tibia, and the proximal fixation was done with smooth K-wires. Cross K-wires. At 3 months, the union was evident distally. Proximally, the wires were removed. At 6 months, he was walking like this, but you could see a bit of a varus collapse, so a bit of an anterior collapse, varus collapse because of the bone resorption. In very young children, we have seen this bone resorption, and indeed at 12 months, he had a stress fracture, but it was a hypertrophic non-union, and we did a CT scan. Pleasantly, we could see that the physis is still growing here. An additional plating was done, and it healed. So now at 2.5 years post-surgery, we can see the limb length is equal, and you can see that this much of growth has happened, as you can see on this zoomed out X-ray. We're still too early into the follow-ups, but I believe this child will have a good equal limb length. Thank you.